Okay, I want to welcome everyone today. This is our National Hispanic Medical Association and our Hispanic Health Network and Latino Commission on AIDS and all of our partners hosting our HIV/AIDS National Testing Day webinar. 1 year later, how COVID-19 impacted HIV testing in the Latino community. So I want to welcome everybody. We're also on Facebook Live. And just a few housekeeping topics. We have presentations that will be followed by a Q&A at the end of all the presentations. And please type your questions in the Q&A box. Microphones will all be muted, but the recording of this and slides will be available next week at our website, nhmamd.org. So our first speaker, Dr. Natali Aziz, Director of Perinatal Infectious Diseases and Director of the Central Valley, that's Central Valley, California, Perinatal Services, Stanford University School of Medicine, my alma mater.
Yay.
Dr. Aziz, take it away.
Thank you so much, Dr. Rios. And good afternoon to all my colleagues from the National Hispanic Medical Association and all other guests who've joined us today. It's truly a great pleasure and privilege to join you and to be able to speak about HIV testing during the COVID pandemic and how that has affected our obstetric care for our pregnant patients. Next slide, please. So in terms of our goal, which is my life goal of eliminating HIV perinatal transmission, the COVID pandemic has had some influences. Just stepping back, I would like to emphasize that prenatal care is a very unique opportunity in obstetrics to provide HIV testing to every single pregnant patient. HIV transmission can be reduced from mother to child from 25% down to 1 or even less, 1% or less with combination ARTs. That is something that's so phenomenal. And generally in medicine, and especially in obstetric medicine, we're usually not that great in terms of our efficacy with our treatments and interventions. So this is an intervention that has so much potential. Again, it's an opportunity that we must maximize in obstetrics, and it's a way for us to normalize HIV testing and prenatal care. It's interesting because I never hear about people refusing their syphilis testing or chlamydia testing, but HIV testing is different, as we all know. So going back to historical grounds, the CDC since 1995 has recommended that all pregnant women be tested in for HIV during their prenatal care. And if infected, they should be offered treatment for themselves, both to improve their own maternal health and to prevent HIV perinatal transmission, which again can go from 25% vertical transmission down to less than 1%. Very importantly, the mothers who are not tested are a significant portion of those who unfortunately have HIV-infected infants. In the CDC's standard data set, in which 33 states report HIV-exposed infants, we see that about 1/3 of those babies who are infected are actually born to moms who did not know their HIV status until after delivery. And I can't say how many maybe just knew at the time of delivery or shortly before delivery. So again, this leads to further opportunity to allow us to diagnose them as early as possible in pregnancy. Next slide, please. And one of the ways of doing this is certainly our opt-in versus opt-out testing strategy in obstetrics and in HIV testing. As most of you are familiar with, the opt-in testing strategy is when a pregnant woman is given her HIV test counseling, and then she must agree to receiving an HIV test, and usually it's done through a written consent where she has to sign. The opt-out strategy, which is so much more beneficial, is when women are told about an HIV test that'll be included in their standard group of prenatal testing, like a hematocrit and a hemoglobin, and all the tests that are given to pregnant women, and then they may decline the test. And if they do decline, a physician generally documents it into the order sets. And unless they decline, the patient will automatically receive her HIV test along with the remainder of her prenatal labs. Now, the benefit of opt-out approach has been seen over the past decades. We know that it increases HIV testing in pregnancy. In 2002, there was a MMWR that was published that demonstrated of the 8 states who used the opt-in approach, their testing rates in pregnancy were as low as 25% and as high as maybe only up to 70%. However, in comparison, Tennessee, which used the opt-out approach, had a testing rate that was actually quite higher at 85%. Other reports have always also been very reassuring in terms of Birmingham, Alabama in 1999. Their testing rates went from 75% when it was opt-in versus 88% with opt-out. And similarly in the Denver Health Medical Center, and this is just a very robust and glorious number, the testing rates are 98% when they have been using the opt-out method. The CDC in 2006 accordingly recommended that the opt-out approach would be used for testing all adults, adolescents, and pregnant women from 13 to 64 years old in healthcare settings. And the American College of Obstetrics and Gynecology is in significant concordance with the CDC guidance, and shortly thereafter came out with their committee opinions supporting this strategy. And California, since I'm from California, started the opt-out testing in the 2000s, and so we've been using it for now approximately for a decade and a half. The CDC recommendations for HIV testing and prenatal care are actually very important. It's not just that first prenatal lab that we want. First, there's certainly the universal opt-out HIV testing for all pregnant women as early as possible in every pregnancy. And I think that that's a very key point. So you never want to delay prenatal labs. And in fact, a lot of people get their prenatal labs before they even come in for their first visit in clinics. A second test, though, is also very important in the 3rd trimester, and again, preferably before 36 weeks, so that if there is a seroconversion, we can act upon it. We use risk factors such as acquiring HIV, for example, injection drug use, utilizing sex work for drugs or money as risk factors for retesting, or high-risk partners. Additionally, other factors for repeating this test include care in facilities that have an HIV incidence in pregnant women of at least 1 per 1,000, those women who are incarcerated, those who live in jurisdictions with elevated HIV incidence, or those that have signs or symptoms consistent with acute HIV infection. CDC also strongly recommends that rapid HIV testing at the time of labor and delivery for women who come in without prenatal care be available, and it is a truly a benefit to have rapid testing on labor and delivery for patients who may need it a second time and didn't have it, or those who've had no prenatal care at all. And then finally, and I think this is an extremely and equally important aspect, is that the CDC recommends exploring reasons for why women want to decline testing. Most of the times, in the past, although it's been few, but when women have declined, I think when explaining to them that this is an opportunity to help protect and prevent perinatal transmission, I think most mothers are then very amenable to being tested, because obstetrics and pregnancy is a very vital time in reproductive life in which a woman is very much in line and very devoted and committed to prenatal care for the health of her baby, and therefore it's a great motivation to actually bring in the perinatal transmission aspect, and that we can do so much by decreasing transmission risk from 25% to less than 1%. And now, just combining our importance of HIV testing and pregnancy during the COVID-19 pandemic, there are many similarities, and it's actually quite stark. Pregnant women are at a higher risk for serious complications compared to non-pregnant women, both age and health matched in the COVID-19 pandemic. There's also a higher risk of adverse perinatal outcomes. So those women who have COVID-19 are seen to have more ICU admissions, more invasive ventilation, ECMO, and even more death by a small absolute value, but still statistically significant than those women who are not pregnant. There's also an increase in preterm deliveries, cesarean deliveries, as well as severe and critical illness. And then finally, there's also been cases where studies have shown that there's an increase in stillbirth. We don't think that it's exactly related to the COVID infection, but we do think that it has something to do with patients not presenting to care early enough when something else is requiring an indication for evaluation, but that they're worried about COVID. Secondly, I think an important factor is that immunocompromised persons have higher rates of COVID-19 complications as well. And then putting this all together, and very importantly for our talk today and for our healthcare providers, the Hispanic and Latinx, as well as Black populations, have an abundantly disproportionate burden of the illness of COVID-19, similar to HIV statistics. So pregnant and non-pregnant persons of ethnic minorities have a higher rate of COVID associated with hospitalizations and severe in-hospital outcomes. Additionally, pregnant women we see have disproportions in ethnicity and race as well. We see in a CDC recent report that Hispanic pregnant women comprised about almost 40% of those that tested positive, and yet were only 24% of the total testing population. And again, we have this similar striking similarity between HIV and COVID, in that we know that, for example, Hispanics and Blacks are also a higher proportion of the HIV diagnosed than the actual patient population. For example, in the United States, Hispanics only make up approximately 18 to 20%, whereas their HIV diagnosis is 27% of the total population. And similarly, Blacks make up only 13% and make up 42% of the HIV diagnosis. Next slide, please. So the importance of HIV testing in pregnancy also goes beyond this. I think it's very important to acknowledge and to recognize that pregnant patients are hesitant to present to actually prenatal care due to the COVID-19 pandemic, and they fear healthcare settings for acquisition of the SARS-CoV-2 infection. So this actually has led in many cases to a decreased or even later diagnosis of HIV in pregnancy, where patients come much later and present later to care, for example, whether it's in the second or third trimesters. Additionally, during the COVID-19 pandemic, there's been limited access to care, I think especially in our at-risk populations, where there are actually limited appointments and office hours, where telehealth was used more often, and not everybody has access to devices or to the barriers that can be overcome to actually use telehealth. There's also travel restrictions due to COVID-19, and thereby this definitely delays care and treatment in pregnant patients for HIV in particular. This actually comes very close to home in that I recently had a patient that was in Mexico, was unable to travel back to the United States due to the COVID issues, and didn't come back until the third trimester, and she had run out of her medications. And coming into her prenatal care, which was in the third trimester, she had a detectable and high viral load. So these are very important instances that are deep-rooted both anecdotally and based on data that we really need to strive to improve this access for our patients. And then finally, I just want to highlight the stigma that our patient communities have regarding perhaps the higher rates of COVID-19 in certain communities, similarly to HIV, for example. In my own home community at Stanford, we actually noticed that the majority of our patients were Hispanic, over 80%, state insured, over 80%, and over 60% were Spanish speaking predominantly. And this is compared to only a third of our patients are both Hispanic or state insured, and only 17% of our patients are Spanish speaking. So there's this stark dichotomy between our patient population makeup and the dramatic differences in our COVID rates and infections and severity, and those that lead to complications. With that, I'd like to also go over the fact that the CDC is helping to promote HIV testing through the pandemic, and through their program of Let's Stop HIV Together and the HIV Nexus. There are multiple, next slide please. There are multiple programs, both for, first of all, screening, and we can go to the next slide, thank you. And one more slide, thank you so much. Oh, I'm sorry, you can go back, I apologize. For screening, for prevention through PrEP, and for treatment and management. So all these resources are very much at your fingertips for this very important aspect of healthcare provision, which is HIV testing of all of our patients through the pandemic, which has its limitations. So again, there is screening, preventing, and providing treatment resources, as well as, this is a very important resource. We could go to slide, I apologize, slide 11, please. So this is actually very important in that this is the latest addition to the HIV Nexus, in which we are trying to address and provide HIV care during the pandemic. The CDC has actually released resources that are available on the HIV Nexus link, which will help with telemedicine. So CDC guidance on PrEP services via telemedicine, as well as how to prescribe 90-day supplies versus 30-day supplies. So continuation of PrEP and STD services, and as well as interacting with patients during the pandemic. So I urge all of you to think of pregnant women and to think of obstetrics as that unique opportunity to help provide a very motivated healthcare aspect in terms of having the ability and the opportunity to help test every single pregnant woman for HIV, and additionally to help destigmatize and normalize HIV testing as well as COVID testing, and again to help provide the best care that we can for our patients. If we go down one more slide, please. One more slide. Slide 16, please. Oh, thank you. So one of the other very important aspects of the CDC and its resources is that it is providing free continuing medical education programs for both the testing, prevention, and treatment strategies, stepwise approach, and it's actually done through medscape.org. And again, I encourage all of you who are interested in CMEs and especially HIV care to please complete this program, which is very helpful. So, and that brings me to the end of my presentation, and thank you for your attention.
Oh, sorry, wasn't muted. So next we have Jason Villarreal, New York-Presbyterian Hospital Comprehensive Health Program, to talk to us more about HIV testing. And I just wanted to say that this program is also being sponsored by the CDC, and NHMA is part of the partnerships within the Let's Stop HIV Together, working with all of the resources that were just mentioned. So thank you for that. Jason?
Hello. Yes, so my name is Jason Villarreal. I'm a nurse practitioner at Columbia New York Presbyterian Hospital in Manhattan in New York City. We're located in Washington Heights. I want to talk a little bit about HIV testing during COVID. So one thing I want to show, I didn't get to put this in a slide, but I don't know if you can see. If you look in Google and where we live, where our hospital is, it actually now is listed as Little Dominican Republic, which I think is very interesting. We all know that being in this area. So I think especially as we discuss the impacts of COVID, of HIV, and that intersectionality also with when you look at structural violence and kind of institutionalized racial barriers, this all came to a head here during this time. But I'm going to focus a little bit on specifically on HIV testing during COVID. So you can to the next slide, please. You can move to the next one. I don't know how to advance that. Okay, so I just got some data from our own particular clinic. So I was kind of a late addition to this, so I didn't really get to actually we can go back one. I think we're a little bit delayed here. I'm really I don't do as much research. I really just see patients and focused on kind of doing that. So I do primary care for people who are living with HIV, and I have a few patients who are on PrEP, and so doing their management, but the majority of my patients are already positive. However, I was curious in light of kind of the topic of conversation today about how we're doing for testing. So we have a unique system in our particular clinic that somebody can be seen same day, whether they're discharged from the hospital, whether they walk in off the street. If they test positive, they can be seen by a provider, and they can even start ART on that same day. There's a program that's kind of an initiative through New York City called IART. So like really somebody walks in, gets tested, and if they are ready and they're willing to start, we can start them on ART immediately. So we looked a little bit at the statistics just in the last, since the kind of before the pandemic began and then throughout the pandemic. So over the course of from fall of 2019, which is a bit, I think it should be 2020, to present, we did 63 tests done via walk-in clinic or walk-in people who just wanted to get testing. And of those 63, 30 were identified as Hispanic, Latino, Latinx origin, which is slightly low compared to our neighborhood, but it's not surprising between Washington Heights and the Bronx. And as I said, I was trying to show this neighborhood by the most recent demographics is approximately 70% mostly Dominican. So I spend most of my day speaking Spanish in clinic. Okay, so we can go to the next slide. And the next slide just want to talk a little bit about a separate aspect of testing, which is for people who are on PrEP. So a few of my colleagues, one in particular, Carrie Carnavale, one of our nurse practitioners here, is very involved, particularly with our youth clinic. And that's defined kind of like in the 16-year-old to about 30-year-old range. So they actually did a study which actually started went through the pandemic of doing at-home testing for STIs during the pandemic. And this was coupled with a New York City initiative to give patients home testing, third generation OraSure testing for HIV. So they tried to combine these, and the way it worked was that utilizing telehealth, they would have the patient fill out a questionnaire first of all, and then find out if they got the OraSure test and they were able to do it and what the result was. And then they would send the patient a kit which had a gonorrhea and chlamydia test, which they could send back to the clinic. So you can go to the next one. The next one, we just kind of talk about kind of some of the demographics of the people who participated in this initiative. And as you can see in the age, it's a pretty relatively young cohort, mostly men, male identified. So the majority of the people that we serve in this particular age group would be identified as MSM, or men who have sex with men. And as you can see also about 54% identify as Hispanic. So you can see that we had a positivity rate of STIs of 13%. And again, this is not specifically HIV, this is gonorrhea and chlamydia, but this is kind of a snapshot or a window into what testing can look like. And as you can see that we can also talk about what the documented results of OraSure testing, the oral third generation. So there was 54%. So again, that wasn't as high as we would have liked, but that was kind of also partly because that was separate from what we were doing through the New York City Department of Health. So we can move to the next one. And so we, as we talk about, 13% came back positive for gonorrhea. Eight of those were gonorrhea, 14 for chlamydia diagnosed. Nobody reported a positive HIV test on those telehealth visits. That being said, I really want to expand greatly on something that Dr. Aziz had mentioned, was access. This is my gospel, my yell it on the mountaintops, is that telehealth is not sufficient. Just bottom line is just not. So of those tests that we talked about, the 63 that we had done as walk-ins, about 30 of those identified as Hispanic or Latinx or Latino or Latina, and 9 of those tests were positive. So those patients, those people were able to get linked into care immediately. And we can move to the next one as I kind of rant. I cannot stress enough the importance of access. Telehealth is not, it's great for certain things. It's great for blood pressure monitoring, for diabetes monitoring to an extent. If somebody has that technology, if there's language concordance, it's hard enough that many patients have to deal with language discordance with an interpreter present. It's next to impossible when you're using a phone and a Wi-Fi, and it maybe isn't that great, and you have another speakerphone with an interpreter. So, and then ultimately, one of the limitations even of the study where they were doing these at-home testing kits is, as people are probably hearing, they used the OraSure, the third generation test. To get the fourth generation test, you need a blood test, which means somebody has to come in. As a matter of principle and policy, our clinic never closed. We are the HIV primary care clinic. And I actually did 2 weeks of triage in the emergency department tents. So I don't know if you remember, in New York City, we had tents sitting outside of all the hospitals. And I did triage in those tents for 2 weeks. Every shift I was there, I was the only Spanish speaking provider, which is a whole nother issue. But we had a cheat sheet saying, where do you send somebody if they have a specialist question, if they have a cardiology question, whatever. And there was all like, call this person, try to do, for anything sexual health or HIV related, they said, send them up to our floor because we are here. So when you have limited access, when you don't have walk-in availability, that is closing doors, that is putting up walls and barriers. Dr. Aziz mentions, how there's stigma associated with testing, and that people, it's hard, it can be hard to do that. So imagine trying to do that virtually, imagine trying to do that via mail-in or whatever. People will, it's just, you have to have that in-person availability. And then, we were open throughout the pandemic for our patients who hadn't been in care for a long time, but now they decided, even though we're in the middle of a pandemic, they're scared now. They want to, so that's why we're still open. So I think it's very important. Testing, HIV testing is kind of one manifestation of what kind of is going on. But I think it's really important to understand that that testing has to be available at all times. Otherwise, you're just putting up boundaries and walls. So that's pretty much all I have. I do see a question about when does somebody get concerned about developing resistance to the medication they're taking if they stop taking after several months. That's a question I think that if someone stops taking it completely from 0, like 100 to 0, the risk of resistance is probably less than if you take it here and there and here and there. That's a kind of a more detailed question, but if somebody just runs out and stops taking it, that's not great, but that's probably less risk of resistance than if they kind of spread it out. So I try to really convey that to my patients.
That's great. So thank you very much, Jason. The next is Jennifer Reyes, who's our health program coordinator from the League of United Latin American Citizens, or LULAC. Jennifer.
Hi, hello. Thank you for having me. Next slide, please. Hi, so I'm with LULAC, the largest and oldest Latino grassroots membership-based organization in the US and Puerto Rico, just in case, some of you may not have known. We are a volunteer organization that empowers Latinos across multiple sectors, which includes education, technology, workforce development, health, and immigration. We're in 46 states. roughly 135,000 members. We are also a partner with the CDC and the Let's Stop HIV Together program. And through this, we've been able to provide opportunities to get tested, or for members of the Latino community to get tested, particularly those who live in poverty or those who may not have access to healthcare services. And LULAC also spreads awareness through social media campaigns, blog posts, roundtables, cafecitos. We do programming at our major events at the national level. So these serve as an opportunity. These serve as an opportunity to connect LULAC members across the country with their national partners by providing information, resources, and health screenings. And our national convention is held in different locations every year. So each year we're targeting new people, getting them tested. We also have our LGBTQ summit, also again informing the communities, and then having opportunities for HIV testing. As well as the Feria de Salud, which provides the Latino community, particularly in Los Angeles, with health resources, and screenings. We've partnered with the Ultimate and Bienestar to provide free HIV testing, condoms, safe sex education, and information about PrEP. And this is now in Dallas, Texas as well. The LULAC National also provides funding for opportunities for local partners, LULAC council members, collegiate councils who want to host these HIV testing in their communities. Our stipends can range up to $2,000, $4,000, depending on how many events you do. And then on the council level, I believe it was in 2019, our LULAC councils in Puerto Rico partnered with Walgreens pharmacies, to get people in that community tested, because 1 in 4 people in Puerto Rico have HIV and are unaware. We have councils in Salt Lake City or DC that also provide these educational events, and then have opportunities for members in their communities to get tested. So this was more like pre-COVID. And then we've kind of shifted towards social media, and virtual events, addressing the stigma within the Latino community, and providing culturally relevant information about HIV and AIDS, in Spanish and English, and then increasing attention to awareness days, and joining Twitter chats. We also, because this year's, HIV testing day theme is, my test, my way. We also want to encourage, people to know that there are many options available to them. There are self-tests that you can order online that are completely free to you. Or, local departments are offering, or local health departments, I apologize, are also offering these free exams. So spreading that information to our community and letting them know that, maybe you can't visit a clinic because, maybe they don't have the capacity, especially during COVID specifically, that you have options like self, testing. And then next slide, sorry. And then, during the pandemic, we kind of had to shift things because, like I mentioned earlier, the lockdown kind of did stop HIV testing in some locations. So as, restrictions began to lift and things started to open up slowly, we were able to have mobile clinics, which were COVID-19 safe. There were strict protocols. No walk-ins. It was only through appointments. So if you had an appointment, you were allowed, to get your testing. And through that initiative, we were able to test 650 individuals throughout Puerto Rico, Los Angeles, and Chicago. And again, we've had to prioritize virtual events, encouraging our community to do self-testing, which is again free to everyone. And if you do have the opportunity and your clinics do have the capacity to visit your local clinics, and as we begin to transition, the pandemic and things are opening up, we are, starting to have, the strategy we used to have before, where we will provide HIV testing at the Texas LULAC convention in August of this year. The Texas LULAC and local health department in Austin partner together, and they will be administering HIV testing during this event. And I am done. Thank you so much. If you have any questions, just let me know.
Okay. Thank you, Jennifer. Our next speaker is Gustavo Morales, Director of Access to Care Services from New York, the Latino Commission on AIDS. Gustavo.
Gracias, Dr. Rio. Buenas tardes, everyone. Thank you for being here. You can move to the next slide, Sophie. So, I don't need to repeat the story. March 2020 happened. We are a nonprofit community-based organization. We are CLIA Wave Laboratory. Our brand, what we leverage is that this is a space where you can escape the world, be in a community in our space, get away of homophobia, get away of transphobia, and just be in community, find your tribe. But March 2020 happens, and all of a sudden, being in community becomes risky. We fear being together. This destroyed, traumatized the people that we see. We all of a sudden became a place that would have been deemed risky. And where would people that usually come to our space would meet if they couldn't come to our space? We had to close our doors on March 13, but we never forgot that we were here and we had to do something. So in a matter of a week, we were able to move into a telehealth, telecounseling model. But like we have already heard, that's not for everyone. So we worked very, very hard to make sure that by June of 2020, we're already back in place, working and providing services to the community that needed so bad. So next slide, please. Some of the main direct impacts that we saw in New York City was a huge exacerbation of mental health needs. I cannot put into words the amount of conversation that I had with clients, with friends saying, HIV didn't get me 40 years ago. I've survived HIV. Am I gonna die this time around? I am 30 years old and I've already lived through 2 pandemics. I've acquired 2 viruses that have put my life at risk. The amount of mental health needed just because of the trauma that occurred, I cannot put it in words. And the access was so hampered. We couldn't find places to connect people. We couldn't find places where the undocumented, the people with insurance or even with insurance could get the services that they needed for mental health. So we have to take a lot of that responsibility, although we're not funded for that, although we don't have the expertise. Something that occurred as well, PrEP and PEP access was extremely restricted. Shout out to Presbyterian Hospital, to SUNY Downstate. Those were 2 of the main partners that we identified that we were able to connect folks to continuously throughout the pandemic, because most of the persons or the clinics that we work with were only seeing existing clients, we're not seeing any new clients, would not have space to see new people, and we all of a sudden got our hands tied up. But sex continued occurring. Sex was used as a coping mechanism, or just because I had more time. And we were at a place where we were answering phone calls nonstop at our home, and we were killing ourselves, pulling our health to figure out where can I get you to get PEP. So that was a very huge impact that was occurred. And just going real quick back to mental health, I remember being in New York City and the nonstop ambulances going everywhere, the sirens. And all of a sudden, there's a directive to control to which people will use ambulances, and the city became silent. And we all knew that silence meant people dying, and people dying a lot. So I cannot put into words how much mental health was affected and is still affected. Benefits and entitlement navigation, once again, extremely restricted as well. finding people who would be able to enroll undocumented folks into insurance, or clients who were eligible for insurance, was extremely restricted, and we were able to do our work, but definitely we got a huge impact on that, and the backlog was huge. Another direct impact was that, let's be honest, HIV testing was not a priority at that moment. The priority was finding food, was getting a job. I lost where I used to work, so we had to shift our gears and take our HIV roles hat and just be there for the community, and use that as a leverage to make sure that we understood that HIV testing was still important, but just meet them where they were, talk about the needs that they had, and then very slightly and on the download talk about HIV and provide an HIV testing as needed. And I want to echo what we've heard already. HIV self-testing is not necessarily for everyone. Not everyone has access to a phone that has video camera. Not everyone has access to good Wi-Fi. The amount of care that we have to work around considering domestic violence, when my family doesn't know that I'm gay or that I am trans, or so many things we're directly impacting our access, and we have to go through that, and we're still living in that world, even though we are working right now in a hybrid modality. So next slide, please. I want to preface that HIV self-testing is not a new thing. It's an old thing. In 2014, the Latino Commission on AIDS already did a survey, and we identified and we interviewed Latino general community. We identified gay and bi men, and we identified the religious community and interviewed them about the accessibility of home HIV testing. And this is back 2014. We discovered that Latino people are ready to use the test. They are willing to use it. They can read it and interpret it correctly, especially if they have had experience with pregnancy tests and other rapid tests that work the same way. So there's no need to be worried about that. But we did definitely identify that only 18.4% of the folks would have used the HIV test when it was appropriate. And what do I mean by that? Most of the folks would use the HIV test as a knee-jerk reaction when I am exposed. But we know that the window period would not allow for a third generation test to provide an HIV positive result if I was just exposed. So that brings back to the importance of, when we're using HIV self-testing programs, make sure we probe, make sure we talk. Many of them are clients for PrEP, many of them are clients for PEP. This is not just about getting the test at your home. And I also want to add how there's another study, the ESTEM study. It was proven, it was between 2015 and 2016, that HIV self-testing is definitely an appropriate strategy to identify undiagnosed HIV infections. So there shouldn't be any fear working around it, as long as, like Jason said earlier, we understand that this is not for everyone, and we stretch ourselves on how to work with that. So next slide, please. Thinking of all that I've said, so for example, we provide home HIV self-testing since the pandemic started, and we made it part of our regular programming, our regular social marketing, but we were also very keen on identifying these folks who, through phone calls, through Facebook chat, through whatever, talked a lot about COVID, said and expressed a lot of fear. We were able to reach out to them and let them know, hey, there is another option out there. You don't need to get out of your home to get the test if you don't want. So we kind of tied up that fear of COVID and bring them options just to figure out how they could get tested for HIV, continue their clinical services as needed, while leveraging all these conversations about COVID. Talking about how accessible it is. For example, in our case, most of the HIV self-testing starts 24 hours before. We need to sit down with the client and explain them how to download an app and how to create an account, and then tell them how to log in. So it's not just a matter of saying, hey, see me at this time, here's a test. No, it requires so much more work for our end, but we were definitely very happy to do it, and it expanded our reach with the community. Something that we definitely work very clearly is that the home HIV self-testing should not be any different to an in-person test. Counselors, our staff are required to convey the same level of professionalism, the same level of probing, the same level of empathy through a home HIV test, just like an in-person test. Next slide, please. This said, because we know that in the status neutral model, both an HIV positive result or an HIV negative result is a catalyst for better health. It's a catalyst for better living. We should not just take it or dismiss it as this one thing. No, let's start deep conversations about how we can live better and healthier, regardless of your HIV result through this test, and to prevent transmission of HIV and other STIs as well. So during all home HIV testing events, and throughout the whole process, we are always accessing barriers to accessing PrEP, IRD, STI testing, emotional health, substance use support, coming up with a very holistic approach to all this conversation with the community that we're serving. Next slide, please. So I'll go a little bit over a few best practices that we discovered in this year and a half. First of all, allocate time for staff to provide services and support outside of the scope of HIV self-testing. We created this thing called COVID emergency support. It was just our staff there listening people, just going, I hear you, I'm here. And we had to invest time in that because that translated in folks getting HIV tests later when they were dealing with their trauma, when they were dealing with their fears. So definitely invest in things that you might consider not necessarily part of the program. That makes a huge difference. Like I mentioned, our HIV self-testing process starts almost 24 hours. Invest time in supporting the clients in getting where they need to be able to meet you. Like Jason said, Dr. Aziz said, telehealth might not be for everyone, but we can do a lot to make sure that it is accessible to as much people as possible. Digitalize any data collection forms. I cannot put in words what a pain it was to have someone accessible through the phone, but everything had to be in paper and running around digitalizing. So digitalizing forms, allowing for the data collection to happen streamlined in a case like ours where we are a non-clinical setting definitely is important. And definitely be flexible. Hey, maybe you have an app that works for telehealth, but you know what? The app is working not good. Hit them through WhatsApp, hit them through FaceTimes, do something else. Don't stick to just what you know, because definitely the main idea is that the client and the patient gets the best service possible. And as cliche as it sounds, I tell everyone in this pandemic, when you come up with an idea, just do it. Don't overthink it. No, just do it. You're going to make a huge difference just by running with it. And you have time to fix errors in the process. Just do it. Next slide, please. So some of the common barriers, and I'll go real quick because we already discussed it. Not everyone has the time to get an HIV self-testing or testing at all through the pandemic. Something that we see a lot. I all of a sudden got a client getting into an appointment while they are doing groceries. How do I ask you about sexual health when you are in the middle of a grocery store doing things? So not everyone is ready for that. We need to communicate very clearly. The fact that this is through telehealth still means it's health related. I will do my best to maintain your confidentiality. I need you to do your best as well to maintain it. We did identify that when HIV self-testing versus in-person testing was offered, many of our regular clients or people that knew us from before chose to go for in-person. And like I said, people like coming here, they enjoy the space. So we had to work a lot in getting a new pool of people that have never been at OASIS, and that definitely helped pick up the HIV self-testing. Clients may not have access to confidential spaces. They might live with partner or family members, so you always got to keep that in mind, as well as domestic violence. And domestic violence is not just a partner. We had an instance where in the middle of a counseling, the landlord of a client came banging on the door, literally to throw this person out because of lack of payment. So you gotta understand that domestic violence is not just, it's the whole thing, and that what might impact the person that you're seeing. Some people do not have necessarily Wi-Fi. Just think about all of that. And of course, another thing, if you use the HIV self-testing model where kits are shipped to the clients, many clients do not have access to a secure place. FedEx or UPS cannot drop the box just in front of the corner. They need to have a secure place, and that's an issue. So think outside of the box, maybe get a little bit extra money and think about paying for guaranteed delivery. Give a specific time, just get out of the box and make it work, please. Next slide, please. So one of the main things that we also identified is that the staff members, the nurse practitioner, whoever is providing telehealth has on them the weight of balancing all the expectations. A patient might think, oh, this is just a quick thing, a 5-minute phone call. They won't be asking me anything. And all of a sudden you start asking private questions and they pull back. So we need to be able to manage all the expectations that we are legally required to, but that the client might have or the funder might have. And we need to balance that for the process to work. And we needed definitely to develop a new pool of clients to make sure that more people access HIV self-testing, because the folks that already knew us or come to our space already had a hunger to be in person in our space. So we had to shift gears as well. So that's what I have on my end. Thank you so much.
Okay, thank you, Gustavo. Now our last speaker, and then we'll have some questions and answers. HIV testing in the Latino community by Victoria Rodríguez-Roldán from AIDS United. Victoria.
Hello, everyone. So in our case, we're kind of the rare instance of an organization here that doesn't provide direct services. AIDS United, our goal is, as a national organization, the ending of the epidemic in the United States. We provide policy work, which is where I specialize as a senior policy manager, programming such as the AIDS Watch Advocacy Conference. We also do programs work and give out grants to many service organizations such as HIP and other such organizations that provide testing and services. And we're very active in that field. AIDS Unite, our policy work includes the Public Policy Council, which has more than 50 member organizations from all across the country dedicated to HIV work, and they range from direct services to advocacy clinics. They are all over the country. Personally, to give a background, which I feel hasn't been given yet, because we might be like, well, what matters so much about the Latino community and HIV? And I would like to move to the next slide. And for the statuses of this data, I'm using US government information. So they're using the term of Hispanic or Latino of any race from the census. That is a very problematic term because of, I like to joke that all of us have had the identity crisis when you're being asked if you're white or black or whatnot in the census, because they claim that you're white, even so you're not, and that Hispanic or Latino. But that is a very problematic way that they classify it, but that's the best data we've gotten. And 27% of new diagnoses in the US were Hispanic or Latino or Latinx. Particularly vulnerable populations, so LGBTQ men, transgender women. We have seen an increase in cases, which are between, I want to say, ages 25 to 34, of 10% between 2014 and 2018. Only 61% of those living with HIV had received some care. This is among Latinx people. 49% had been retained in care. 53% were virally suppressed, for all the reasons that the more treatment provider folks here have been mentioning, which is how difficult it is for people to remain in care when they're struggling to make ends meet, when they're worried about other aspects of life and so on. And I can keep on going. That's why we cannot do the discussion of minority health issues, which is another topic I feel is under addressed in this webinar today, without talking about mistrust in the healthcare system as a product of discrimination and mistreatment. Among immigrant communities, this will be compounded by fears of deportation or loss of legal status and so on. And let's face it, it wasn't until that long that there was a ban on anyone living with HIV from coming in from abroad, an immigration ban, which actively would discourage them. And in the process, we cannot address access to testing, we cannot address access to treatment without addressing why is the medical community so mistrusted among minority communities? Why if there's so much discrimination in the medical community, so much mistreatment, that people are afraid to open up about their life to a health provider, no matter how well-intentioned that health provider is. And to be very honest, there are plenty of racists in the healthcare community, and I don't want to insult. I have a habit of being invited to speak at med schools and then not being invited again because I will tell everything that's wrong with the medical profession, but that's another matter. If we could move to the next slide. We have seen, as we were seeing, a decline of HIV testing and by extension of diagnoses, but that doesn't mean, as we've been saying already, that sex and drug use hasn't been happening. On the contrary, those things have been, probably are happening even more due to the escape from stress. This isn't like, to use the overall global pandemic isn't exactly the time to quit cold turkey on bad habits that you use as a coping mechanism, to be very honest. Among our member organizations, we have been seeing problems of people dropping out of PrEP and antiretroviral treatment because of the pandemic for the obvious reasons, like loss of access to healthcare, like loss of employment, fear of access, fear of contracting COVID if they go in person to a doctor's appointment, and I can keep on going. Some providers are talking about greater accessibility of treatment, though, because of the sudden availability of telehealth options. And that it's like, yay, we have people who are struggling to come into the office or make the time to come there, or who live in remote areas and thus can't travel 50 miles every doctor's appointment to come in to get tested or to get treatment. They're having access to treatment through telehealth. But as I always try to make it clear, it is not a panacea. We cannot treat it as a substitution to in-person treatment, while it should be maintained as an option for healthcare even after the pandemic. It is simply not accessible for people living in unsafe situations, victims of domestic violence, for many people who are in unsafe housing situations. And for that matter, it lends itself to instances where people, as Gustavo was talking about, show up to discuss their sexual health while doing groceries. And I keep suddenly remembering the doctor who showed up to a traffic court hearing on Zoom while performing a surgery, if people remember that viral video. To be very honest, I did not try to cite any 2020 figures on HIV diagnoses because they're going to be skewed. Like, a lot of people didn't get tested, well, they kept doing the same behavior. It's going to be lower. And we're going to start seeing an uptick as we start reaching out to people again. I realize that there is a big goal among organizations, even here at AIDS United, of ending the epidemic and by 2025. That is the dream of the White House, of many in the administration, but I don't know if we're going to get there because precisely of COVID. In the process, we are also seeing a problem where one of the we're working with the workforce development people for development of the medical profession, is that we have had a sudden, okay, I'm about to be kicked out. Wow. We have been having trouble with, never mind, I'm losing my train of thought. I got distracted. I think we can end it there with that. I'll stop rambling.
Okay, thank you, Victoria. I think you ended on a positive note that we need more Latino doctors and nurses and caseworkers and community health workers. And I think what you were trying to talk about was the importance of of being more relevant and more culturally competent, you know, language appropriate and everything else that we know the health system is not. And I think that the HIV/AIDS data, as you said, will be starting to uptick because people will start going back to their doctor and getting tested and being a little bit more aware of other things besides social isolation and mental health, about grieving for people that have died this year. And we probably won't reach ending the whole HIV epidemic by 2025. But the point today is, how do we increase testing among our community, especially men who have sex with men, transgender women, females, that are the group that seems to be the groups that seem to be the most at risk of HIV. And despite the country seeing that HIV has decreased because of great medications and testing, the Latino community is still going to be in much of a need, and we're going to need much more support from CDC to continue all the good work that all of you guys are doing. All your organizations, whether you're testing or not, you're educating people about HIV. So I think it's very, very important. Thank you very much for everything you guys all have said. So just a few questions. One question, I'd like to know, what do you think are messages that your organization has seen as important, impactful to increase testing? Just a simple message. We heard a lot about the barriers, but let's talk about strategies. Dr. Aziz, do you have any message that you think is important? You're on mute.
Thank you,
Okay.
Dr. Rios. Regarding perinatal care and obstetrics, I definitely think testing is dedicating yourself to a healthy pregnancy and a healthy baby. I think that's the most important thing for me, and comes from my heart and soul. And that's what I try to convey to my patients, that testing is dedication to a healthy pregnancy and baby.
Okay,
And
great.
lifelong. It's a great opportunity to promote that health through lifelong efforts as well, and treatment.
Okay, that's a great message. Gustavo? I'm just looking at my screen here.
Real quick, not only the message, but the language in Spanish many times over and over. You're not alone. We're here. This is part of your healthcare, and we're your partners in their healthcare.
Oh, good. And family too. Okay. Jason?
I would just say that we're open. We haven't closed. Please walk in. And it's very important. I just said this to a patient today. He said, "Oh, I've been good. I haven't had sex." And I said, "Wait, that being good and having sex have nothing to do with each other. Sex is totally normal. Sex is not good. It's not bad. It is. And it can be something very good, very beautiful. So don't think you've been dirty. Don't think you've been bad or whatever. Just live your life. And we're always here ready to do testing, ready to do treatment, and just keep living."
Okay. Jennifer?
Hi. Basically, we just like to get the message out, like this disproportionately affects our community, and just you need to get tested, and it should be treated as if it was just any other, like, test, and always just encouraging our community. Yeah.
Good. Just reminding. And Victoria, what's the message, especially in your policy work? What do you think?
I would say one message is to fund, for policymakers to fund completely all testing, and for healthcare providers to be literate in testing and in HIV care, so that everybody is reached out whenever they come in contact with healthcare in general.
Okay. No, those are all very great messages. There's a question here for Dr. Aziz. It's specific to you. It says, can you address COVID vaccination of pregnant women? And has this alleviated concerns about accessing prenatal care?
Thank you. So first, I'd like to just say that we have a robust amount of data through COVID vaccination of frontline workers who were pregnant. We have over 30,000 data points, basically, of women who received the vaccine as frontline workers. And there was actually no unexpected events of adverse events. There were no increase in congenital defects. There was no increase in adverse perinatal or obstetric events such as preterm delivery or preeclampsia. So I'd like to just really emphasize that the vaccine is very safe for use in pregnancy. One of the worries that I have is that people want to wait after their pregnancy to receive the vaccine. And that I want to just encourage people to accept the vaccine as soon as they become pregnant, because pregnancy is a high risk factor. Our communities in the Hispanic and Black patient cohorts are at higher risk of acquiring the infection and both COVID and HIV. And that puts us at a greater risk of severe outcomes. And furthermore, being vaccinated afterwards isn't as beneficial as being vaccinated during your pregnancy for the health of healthy term delivery and a healthier mom. So I definitely would like to encourage all pregnant women to receive the vaccine if they haven't during pregnancy, but preconception vaccination is a wonderful idea. And there were some rumors about the COVID vaccine causing infertility, and that was completely unsubstantiated. There's absolutely no evidence for it. And I would highly recommend, please seek out medical advice if that is something that you are concerned about. But certainly vaccinating now, vaccinating as soon as possible, and vaccinating the community are things that we should all be doing, whether you're pregnant, not pregnant, whether we're Hispanic or not Hispanic, anything, we just need to be vaccinated. And so I think it's very important to keep that in mind, especially if you're higher risk factor, but all throughout as well.
Okay, let me switch gears here to talk to Gustavo and Jason. Both of you, if you can answer, what do you think needs to be done, especially for the underinsured or the undocumented, people that feel like they, they're marginalized? How do you get them in to testing and especially for HIV, for the high risk Latinos?
I can jump in real quick. So, just be clear, this is very New York State specific. Fortunately, in New York State, there are many options for folks, even if they don't have a documented status. So putting that word out there, because many times I see many folks who come in thinking, I won't be able to have this. And I have to say, yes, you can have it. There's Prep Up. There's so many resources out there. So communicating and messaging. The barrier is not knowing that you can definitely be eligible. So let's bring that messaging down and let people know that, yes, you can get services, even though if you're undocumented.
Okay, and I think it's important. Jason, yeah.
I'd say the same thing. I mean, my clinic specifically only sees patients who are uninsured, underinsured, Medicare, Medicaid. So that's all I see. And one thing that I would definitely add, this is more advocacy and more bigger kind of macro level, is talk to people in the community about becoming nurses, becoming doctors, becoming policymakers, becoming people who have that voice, because the only way we're going to get change is if we are in the room and we are at the table. And that's thinking more long-term. As Gustavo says, first get somebody in, get them to care. Our door is open to anybody. It doesn't matter if you just, came here from wherever, it really doesn't matter. And we never ask, we don't make any discrimination. They do ask, like, if you have insurance, and if you don't have insurance, that's fine. If you don't have documents, that's fine. And I'm pretty sure to varying extents that's true in different states also. But the main thing again is we need presence. We need to be visible.
Okay, and let me ask Jennifer, at the LULAC conferences and meetings since COVID, it's probably more virtual than anything else. Have you learned anything from COVID-19 messaging to help focus on HIV? Any lessons learned?
Well, I kind of did just start, but sorry, can you repeat the question one more time?
Well, just at LULAC with all the people talking, having meetings, all the different councils. And I know you're a new worker to LULAC, but you know, what do you think has been learned from all the focus on COVID as an infectious disease virus that you could say would be important to keep talking about, but about HIV? So let's learn from what we've just gone through and make it more HIV specific for the program.
So definitely with like COVID-19, you know, how we subsidize like the vaccine. I feel like that could be done with, you know, HIV, like the same efforts that were put into COVID-19 that, you know, to getting everyone vaccinated and trying to hit our national goal, which we haven't hit yet. But if we put the same kind of energy towards other like health crises, we could really, you know, make a difference and be investing in our communities, our, you know, public health. Yeah.
No, and that's critical because even the Affordable Care Act started with a big pot of money for public health, and it got taken away bit by bit by bit. And if we learned anything, it's important how important it is to get people to know about knowledge about their public health programs and resources and the community organizations, because sometimes people don't have time that are working, right? 2 jobs, whatever, don't have time to go to the doctor. And if they go to the doctor, it's when, you know, they're going to the emergency room. Victoria, let me ask you a question. I know we're running out of time here, but you talked about your focus on policy. So what's the #1 policy recommendation as we enter the 5th decade of HIV in this country?
I would say, I mean, as we go, we are trying to accept the idea that we can finally end this once and for all, that we can end, even if it's starting in the US domestically, the epidemic, or bring it down to that level, that much like we've defeated that the technology of the COVID vaccine, the mRNA vaccine, we may actually have an HIV vaccine in the next few years, in the next 5 to 10 years. Who knows? That with PrEP, we already have the technology to end this. It's a matter of public will, it's a matter of public funding for it, and of public education. And sadly, of politics and stigma also.
Yep. Dr. Aziz, let me ask you as the doctor here, what do you think is the way to get more young people, especially from Latinos, from our communities, to get into medicine? Whatever, nursing, you know, any, just to think about all the fulfilling jobs and opportunities within healthcare.
That's a wonderful question. And I think as physicians and healthcare providers and social workers and everything else, I think every time you meet a young individual, I think encouraging them to do it. I have my pregnant patients who are so amazing and diverse and have all these wonderful gifts to give our communities. And I'll often say, you know, you should go into medicine. You should look into being something that is medically related. You have a knack for it. I think we need to speak up. I think we need to connect with our clients and our patients on that level and recognize their skills and their commitment, because I think there's nothing more motivating than having been in someone's shoes, for example, for a young woman to have a high-risk pregnancy, to be HIV positive, to have a baby that's HIV negative. I think those are the most inspiring things, and sharing your story through a healthcare field. I think, you know, we try to keep very prim and proper, but I'm a little bit of the opposite. I think you need to share your story to motivate others and to motivate your patients. It's a very blessed, you know, communication and connection.
I think it's great. We're going to have to wrap up here. I just want to, on that note, I want to thank all of you for being a part of this event. We have information here on how people can contact NHMA. And again, our website, nhmamd.org, will have the recording and your slides available next week. So let your friends know, anyone that was on the participating today with us, and we thank you all. We just a couple things. I think I need to say that we have a very big campaign called Vaccinate for All. And we are supported by CDC, Johnson & Johnson, and Bio to educate more people about the importance of vaccines, especially with COVID-19. And especially now that the younger people under 30 are really, you know, they think they're invincible, as we all know. And even the youth down to age 12 can now get vaccinated. And I think the most important message we can all tell everybody, HIV or COVID-19, is that you need to take care of your family and stop transmission of disease. Whoever your family is, your partners, your family members, your grandparents. And I also want to just mention that we do have a lot of other activities at NHMA. We'd be happy to collaborate with all of you that are here today and with others. If you have any ideas on how we can improve our webinars for HIV and our webinars for COVID-19, we'd be happy to hear from you. And I want to thank the staff, Jasmine, Vincent, Sophie, that are all on the background there. And lastly, I just want to say that we're very excited about HIV Testing Day. It's a great opportunity to educate people and let everybody know how important the day is. And thanks.
I'm sorry, just to interrupt. I just want to say real quick, I put in the comments that there was an initiative I took part in about making videos about the vaccine questions, HIV, pregnancy, anything you could possibly think of, with me and other promotoras de salud and doctors and nurses, English and Spanish. So I put the link in the comments, and these videos are meant to be shared completely liberally. No, you don't need to worry about anything like copyright or anything like that. And actually I'm seeing you just put another slide up with Dr. Shapiro. Now he's actually in one of the videos also. So he and I, you can see both of us there.
Yeah, we've got this, and just to give a plug for our next video here, this is we have a monthly COVID-19 virtual briefing, the last Wednesday of the month. We ask our different partners, and we're having the White House, Dr. Cameron Webb, who's from the White House COVID response team, and others. You can see all the logos on the bottom here. We welcome people to come and hear about myths and the myth busters. We're looking for speakers again for COVID-19 as well as HIV. And Jason, you know what? We have a new website, hispanichealth.info, with resources for different diseases. And we'd be happy to link to any videos and other fact sheets that people use in English and Spanish so that we can share. And we hope to have that up in July, in a couple of weeks. I think right after the 4th of July, we should have it up. So thank you all again.
Thank you.
See